I'm Kieran Horgan. I work as a consultant breast surgeon in Leeds, and I'm the clinical lead for the National Audit of Primary Breast Cancer. Audit in its widest dimension is looking at what has happened, what has been done, and trying to assess various aspects of actions that have occurred to try and make sense. Do we really do what we think we're doing? How frequently do we do it? Do we do it in a certain way? Has it been beneficial or as we thought it would? Or are there things that we should have done that we haven't done? And much the same in clinical practice. We tend normally within every hospital to review the actions that we've taken, usually for the previous month, and see how patients have got on, have complications or difficulties arose that could have been examined more carefully or been avoided. The audit process nationally looking at breast cancer looks at all aspects to do with breast cancer care. Yes, I will sit on the board for the metastatic, and the clinical leads for the metastatic sit on the primary, and we've all worked together in the past. We had a national audit of breast cancer before this, which was primarily of older patients. We were looking at specifically how patients age 70 and over were managed to try and get insights. Were they getting the treatments that perhaps they should have over that period of time? And we formed a team, and we learned how to put the various data sets, as they're called. There are enormous amounts of data that are gathered nationally, often in different silos. And what the audit has been able to do is to combine all of those. They're all anonymized, so patients needn't have any fear that their own data is ever identified, but they're brought together at an individual patient level. So we can look at one, for example, Mrs. Smith. We can see how she was diagnosed. We can see what kind of cancer she had. We can do that in some detail because there's a lot of analysis of cancer done these days. We can then see what treatments. Did she have surgery? Did she have radiotherapy? Did she have chemotherapy? And then within those spheres, we can see what type of treatment she had. So a great deal is possible with the combination and mixing, if you like, of all of the different data sets. That's a very valid question. And what we've tried to do is to look at what we think might be the issues that will arise, but try to have an open mind as well, so that we're not going into it with set views. And we've recently done a broad canvas of all people involved in the care of patients with primary breast cancer to try and see what are the things that matter to them. And we've had a terrific response, including from many, many patients. Now, within that, there are certain things that we will look at and we will be able to look at. There are other things that we would love to look at, but we don't have that kind of information collected. As regards to primary breast cancer, because it's relatively new to be able to look at patients at all ages, the types of things that we would like to concentrate on are the presentation of cancer in younger patients. There are subgroups of patients called triple negative cancers, which often have aggressive cancers. We want to see how they get on. Are they diagnosed quickly? Do they proceed to the treatments that are recommended? And what type of outcomes do they have? And there are smaller groups of patients, but have great validity and importance, such as breast cancer in men. And there are probably thousands every year of male breast cancer patients living in the community, but they've never really had an overall report on how they are looked after and how they are cared for and what type of treatments they receive and if they are receiving all the treatments that they should.